I am really excited to introduce Caitlin O'Connell. She and I met actually when Ethan was inpatient up in Boston in February. She swung by our room when he was recovering from a surgery. She is the nurse practitioner with the Heterotaxy Program that Dr. Shidlow introduced to us. And she's going to talk a bit more about that and a bit about kind of navigating the world of second opinions, which is something that our families do a lot of. So thanks for being here.
Thank you. Thank you so much. All right. Well, I just wanted to echo the sentiments of all the other speakers that I'm just so grateful to be here and to have been invited to chat with you guys. I think that the work that you do is amazing. This conference has been great so far. So I know I'm so grateful that our families have this as a resource. Basically, I have been working in cardiology now for all 14 years of my nurse practitioner career. I've worked in a variety of settings, both inpatient and outpatient, and joined the Heterotaxy program last year to be the first nurse practitioner for the program. So it's been a great ride, especially the last year, learning so much about all the other disciplines. I of course have a great foundation in cardiology, but learning, all of the aspects of immunology and pulmonary and genetics and GI and how those different body systems impact our patients has been a great learning experience for me professionally. Also just wanted to add, just hearing from other folks talking today is giving me a lot of thinking points for ways that we can make our program better moving forward. So it's been really great so far. So a little bit more about the Heterotaxy program at Children's Hospital in Boston. You saw this slide earlier that Dr. Shidlow showed. We are so fortunate to be able to care for a lot of children with heterotaxy at Children's. And that was one of the reasons why the program came to be. Actually, let me take a step back and just say that I'll be dividing my talk into 3 different sections. First, talking about our program at Children's, and then I'll talk briefly about the 5 body systems that are most impacted by heterotaxy syndrome. So cardiology, pulmonary, immunology, genetics, and GI. We'll talk about the different way that those body systems are impacted, as well as how we work our patients up as part of the heterotaxy evaluation. And then thirdly, I'll go through and just show some of the different pathways that different patients take after they've been referred to us. So again, our population of heterotaxy patients at Children's is quite large. And that was one of the reasons that Dr. Shidlow and a variety of other colleagues within the institution decided that it was probably better to take a systematic approach to caring for these patients in order to optimize outcomes, and felt that they had a great opportunity just because of the large amount of patients that we see. The mission statement Dr. Shidlow shared earlier today, but our focus is on recognizing the multifaceted approach is the best way to take care of these patients and not just focusing on cardiology. Our mission statement as a program is to provide comprehensive multidisciplinary care to infants and children with heterotaxy syndrome, including screening, management, intervention, and follow-up. And our hope is to optimize outcomes in this patient population. I made this little timeline just to show the growth of the program over the last couple of years. So the Heterotaxy program launched officially in 2020. At that time, Dr. Shidlow worked with other leaders throughout the hospital to convene a panel of experts in the variety of disciplines that I just mentioned. These specialists would meet on a monthly basis to define what workup we thought was appropriate for the patients, and also started providing some inpatient consultations at that time. Later in that year, the Heterotaxy Patient Registry was created. So that is a database that is housed in a REDCap database and collects information not only on a child's heart defect in the different aspects of that, but also the other body systems that can be affected by heterotaxy syndrome. In the middle of 2021, the leadership within the Heart Center recognized that a nurse practitioner could add some value to the program just by being one dedicated person to try to help families manage all the different consultations and coordinate care. So I joined the program in the middle of last year in 2022. It was a steep learning curve for me. I was so grateful to have my background in cardiology and also to have established relationships with folks throughout the program, which really has helped me kind of integrate the different pieces of the care and bring it together, for our cardiology patients, but really all patients with heterotaxy syndrome. So at that time, I spent quite a lot of time trying to get to know the other subspecialists, learning from them and understanding how I could best support their programs and offering the best care to our children with heterotaxy. I spent time with the pulmonary team from the get-go, learning how to perform ciliary biopsy. So that was something that I was actually credentialed to do later in 2022. That has been great because that is often something that the pulmonary or the otorhinolaryngology teams will recommend for the patients, but actually getting it done in a way that works for the patient was identified as a challenge. So that has been really, really helpful to our patients and for the clinicians caring for them. I also, towards the beginning of me joining the team, we kind of looked at all of our patient education materials that we had and tried to develop some more that could be useful to families, as well as updating our program website to make sure that we were sharing the information that we have with families. And I'll provide the link to that at the end of my talk. Later in 2022, we launched virtual visits for heterotaxy families, and this was super well received by families because, as you guys know, it's not easy to make the trip into these major medical centers dealing with traffic and all that business. So people are really supportive and really seem to enjoy this option. Earlier this year, we started seeing children and their families who were traveling to Boston Children's who would be having procedures with us, either cath or surgery, meeting those families before they even arrive in Boston. So this would be virtually as well, gathering any records that they have had, any workup done at other institutions, and then, putting into place any evaluations that they may want to have while they're in Boston already. I'll talk a little bit more about that as we at the end of my discussion. Within the last month, we were able to add a pediatric GI provider to our team, which has been excellent. Before then, we did have a GI provider on the team who was more focused on hepatology, but we added a general GI provider to our team, who I think will be super beneficial and helpful for families. And then to date, we have reviewed more than 70 patients, done a comprehensive heterotaxy review on those kiddos, and also recently started forming a partnership with our colleagues in the maternal fetal care center, just to start some of the education prenatally, as Kelly alluded to in her presentation. Such an overwhelming time for families who are learning about not only a congenital heart disease diagnosis, but also hearing about a heterotaxy diagnosis can be quite overwhelming. So we're of the notion that more education is better, and we are starting to meet with families during their time with the MFCC. So the next part of my talk, I'll just go through the 5 body systems that are most commonly affected by heterotaxy syndrome, talk a little bit about how they're affected, as well as how we work up our patients. So first and foremost, with respect to immunology, many children, as you guys know, have spleen involvement. And when there is spleen dysfunction, children can be at higher risk for infections. Soon after I joined the heterotaxy team and working with our colleagues in immunology, I learned that it's not just about the spleen. Children with heterotaxy can have other immunological problems as well. And for that reason, it's our approach to kind of do a broad assessment, a global assessment of their overall immune function, rather than just focusing on the spleen function. So what do I mean by that? I mean that the immunology providers will recommend a large panel of tests to look at different percentages, for example, of a child's white blood cells, and do they have the appropriate T cells and B cells? And for older children, they'll often request antibody titers, which can measure whether or not the child has responded normally to the vaccines that they've gotten. So in addition to that, which is a more global assessment of the overall immune function, we are looking at tests that look at specific splenic function. And those include some tests that I'm sure some of your children have had, such as there's a test called an pitted erythrocyte percentage, as well as a blood smear to look for something called Howell-Jolly bodies. Those can be indicative of splenic function. And then there's other testing that's available, such as spleen scans. There's a scan called a spleen scintigraphy scan. So that is some of the lab assessment that we do, but we also do imaging to assess whether or not any splenic tissue is present. As you can see in the diagram that I included, children that have heterotaxy can either have a normal spleen, a normal appearing spleen that might be located in the wrong place. Some children have multiple spleens, and then some children have no spleen. So the abdominal ultrasound helps us to, understand a little bit better about how much splenic tissue is present. Our immunology colleagues are also super important in reviewing with families the different ways that they can reduce the risk of infection in their children. And those include discussing such things as antibiotic prophylaxis. So, as you guys very well know, certain children need to take antibiotics on a daily basis to prevent infection. And then there's additional recommendations before certain procedures, such as bronchoscopies. This team is also super helpful in developing fever management plans with families, as well as making detailed recommendations for which sort of immunizations may be appropriate for that child. With respect to the pulmonary manifestations in heterotaxy syndrome, two of the things that we're looking at, first of all, Dr. Shidlow mentioned this morning, but we're looking at the imaging that the child has had done so far to understand whether or not there's any airway abnormalities or abnormalities of the actual lung structure. That is important for us because it helps us rule in or rule out a patient in terms of whether or not they actually qualify to have heterotaxy syndrome and whether or not they meet the diagnostic criteria. For most patients, there isn't a lot of clinical consequence to having, abnormally shaped airways, but it is something that's important for our anesthesia colleagues to know when they're doing things like placing breathing tubes. Another important piece of our of the pulmonary manifestations in heterotaxy syndrome is something called PCD, or primary ciliary dyskinesia, which I'm sure we'll hear a lot more about tomorrow. But very briefly, PCD is a disorder of the cilia. Cilia are a hair-like projection on the cells that line the respiratory tract. So all the way from your nose, all the way into the small air sacs in the lung called alveoli. Basically, what happens is that in some children, the cilia are either malformed or don't work properly, and their job is to promote normal flow of mucus up and out of the airway to keep the airways healthy. So if they are malformed or don't function properly, then those children can be at risk for things like pneumonia, recurrent ear infections, and recurrent sinus infections. So how do we screen our kids for this? There's a variety of tests that can be done depending on how old the child is. We tend to take a very proactive approach to screening our patients in terms of their pulmonary status, that being because at Children's, we do see a fair amount of complex cardiac illnesses, and our thought process is that we'd rather know, anything we can that will help us along their care pathway. So we do screen many of our patients with nasal ciliary biopsies, including all of the neonates that we're caring for, the newborns. And the way that we do this is there's something called a nasal ciliary biopsy. So I put the picture there of the actual brush that I use. It's called a cytology brush. Basically, you're just collecting a small amount of cells from the inside of the nose and looking at those cells under a microscope. So that's actually a picture of one of our patients that we screened a couple of months ago, and he was determined to have PCD. He was a young child. For older children, there's another test that exists called nasal nitric oxide screening. So this is a test that is done in the pulmonary clinic. It's basically a test you can do around age 5 years and up, because the kiddo has to be able to perform certain breathing maneuvers in order to get an accurate measurement. So those are two tests that we do pretty routinely for our patients at Children's. And also meeting with families before they even arrive and trying to get a good understanding of whether or not there is a history of things like frequent pneumonias and difficulties after past cardiac procedures kind of will put up a red flag to us that we need to take a little extra care in terms of their pulmonary management. I know you can't really read this last picture that's on the right here, but that is a picture of our pulmonary management and our airway clearance algorithm that we work with our colleagues in the intensive care unit whenever we have a suspicion that somebody has difficulty clearing mucus, that will implement this airway clearance algorithm at that time. In terms of genetics, we estimate that approximately 40% of children that undergo genetic testing for heterotaxy syndrome will be able to have a diagnosis identified. There's a variety of tests that we do. I listed the 3 most common tests that our genetics team recommends. I'm not a geneticist, so I will do my best to explain to you the differences between these tests. They're listed in order from lowest to highest resolution. So your first test listed there is called the chromosomal microarray. Basically, this is looking for chromosomal deletions or duplications, whereas the heterotaxy gene panel is looking for specific genes that we know are related to heterotaxy syndrome. They're looking for those genes. And I actually should add here that our heterotaxy gene panel includes about 56 genes now at Children's, and it is inclusive of all the genes that we are aware of for PCD as well. And then the third test is called whole exome sequencing, or WES. And what is an exome? So the exome, as it has been explained to me by our genetics team, is the region of a child's DNA that contains, it's about 2 to 3% of the overall DNA, but it is thought to be where most genetic changes occur. So this test is going to screen that whole area to see if there's any genetic mutations that could be identified. Somebody at one point in all the learning that I've done over the past year plus likened the differences in the testing to a cookbook analogy. So if you're thinking of all of a child's DNA contained within a cookbook, the chromosomal microarray is going to be looking for deleted or duplicated chapters within that cookbook, whereas the heterotaxy gene panel is scanning all the text to look for specific ingredients or genetic changes that we know are responsible for heterotaxy syndrome. And then the whole exome sequencing is going to be looking at 2 to 3% of that overall textbook to look for genetic changes that we know are related to heterotaxy syndrome. In terms of GI and general surgery, there are many different ways that the GI tract can be impacted in children with heterotaxy syndrome. The one that I'm sure that most of you have heard of is intestinal malrotation. So in brief, what intestinal malrotation is, during fetal development, what normally happens during intestinal development is that the intestines lengthen, and then they perform this very complicated twisting maneuver so that they end up in the correct location, which is pictured there. At that time, some connective tissue structures also form, which hold the intestines in their proper position. What happens in intestinal malrotation is that process goes awry, and you are left with intestines that haven't rotated properly. So why do we worry about this? We worry about this because children that have malrotation have an increased risk of having something called a volvulus, which is an intestinal obstruction. And when that happens, a LAD procedure is performed, which I'm sure many of you have heard of. I included a picture of it because I thought this was a great representation of what a LAD procedure actually is. So the top pictures there is the surgeon actually untwisting the intestinal obstruction that has happened, and they actually are dividing some of the connective tissue bands that are there and then trying to leave the intestines in the most favorable arrangement to avoid or to minimize the risk of future obstructions. Historically, there's been a great debate about whether or not we should be screening all of our patients with heterotaxy syndrome for malrotation. And when we find it, what we should do about it. Should everybody have a LADS procedure or not? The current thinking is based on expert consensus and different research reports that have been released, is that universal screening for children with heterotaxy syndrome is actually not recommended for those that are asymptomatic. And same with the LADS procedure, is not something that we are routinely recommending for patients who are not symptomatic. I would say the caveat to that is patients or children who may be going for a G-tube, and so they're already having a procedure. We advocate that the care teams have a careful discussion about whether or not a child should undergo screening at that time. What we do for every family, though, is we make sure that families are well aware of the signs and symptoms of an intestinal obstruction or a volvulus, so that they know, that would be an emergency and reason to get your child to the nearest emergency room immediately to have that imaging done to see whether or not malrotation is at play. With respect to cardiology, Dr. Shidlo covered this material so nicely this morning, but the only thing I would add is, as you guys know, there's a very wide spectrum of how the cardiac system can be affected in heterotaxy syndrome, ranging from very mild involvement to very severe involvement, including some of the most complicated single ventricle heart defects that we see in cardiology. So our role in terms of the cardiology management in these patients is not to take over, the primary cardiology role for the patients who are referred to our program, but rather, serving as a resource to discuss different imaging techniques that may be beneficial, such as the ones that Dr. Shidlow discussed this morning, such as CTs, MRIs, 4D flow assessments, et cetera. And then in addition to the structural issues that we can see in children with heterotaxy syndrome, there's often a fair amount of them that experience heart rhythm problems too, estimate approximately 40%. And that is the reason why we advocate that all of our children have a ambulatory rhythm monitor. So that may be a Holter monitor in your institutions, or there's a variety of other fancy patch monitors that are offered. But that just gives us a good assessment of what the child's baseline heart rhythm is, so that we have that information for, Dr. Shidlow gave the example this morning about, worried clinicians standing at the bedside when they see changes in the child's ECG, and to have that background information, knowing that this is something that's normal for the patient, can be really helpful. We also offer intraoperative EP mapping for most patients who are coming for surgery that have heterotaxy syndrome. And this program has been super successful in reducing the risk of postoperative heart block, and particularly in patients with heterotaxy syndrome, and therefore obviates the need for a pacemaker placed in the postoperative period, which can be huge. So now I'll just chat about the different referral pathways of what it looks like as different children get referred to our program. So for the newborn population, hopefully these are people that we're meeting, families that we've already met prenatally. That is something that we're actively working on. After the baby arrives, we meet with families in the intensive care unit and kind of set the stage for what the evaluation will look like. At that time, we activate the evaluations by our subspecialty colleagues. So genetics, immunology, and pulmonary will come by and meet with families to go through, what their evaluation processes will look like. And then from that point, once the child is born and has been evaluated, they land on my spreadsheet. I keep a spreadsheet so I can keep track of all the kiddos to make sure that all the recommendations have been made are actually, being done. Because as I'm sure you guys know, when you're working amongst a variety of disciplines, what one team might recommend just, might fall through the cracks and not get done. So, we have had a lot of success in making sure that, we're able to complete as much of the heterotaxy workup while the child is still inpatient as possible. And then for those that still may need a couple, pieces of their evaluation, I follow up with the family's outpatient to make sure that, the next time they're coming in for their cath or what have you, that we can get the additional testing at that time. We also stay involved and available to the families and the care teams while they're inpatients to make sure, whatever assistance that they need, that we can be helpful with that. The next referral pathway to talk about are the patients who are local and regional to Children's. Basically, these children are referred by their primary cardiology team. And as I said before, we do not take the place of their cardiology providers, but we work with them, mostly to look at all the other body systems and make sure that the children have been properly evaluated in that way. So these children are ranging in age from late school age all the way up to, teenagers who may have been stuck on amoxicillin when they were babies, and just nobody has asked the question, well, do we still need to be on this? So this referral pathway involves the initial referral, and then we gather whatever medical records are available to us. And then I'll meet with the families virtually to go through all that information and ask a couple additional detailed questions. And then from that point, I discuss with the families what different evaluations they may want to consider. And then whatever folks are interested in pursuing, I work with our administrative support. We have a program coordinator who is excellent, and she's typically successful in trying to arrange the appointments over a 1 to 2 day period to minimize the inconvenience to the family. Once all of those evaluations have occurred, I follow up with families by phone. to make sure that they understand all the information provided and just to kind of talk about, where to go from here, what testing they'd like to pursue, and then help arrange that. And then, the families are given, our contact information and can reach out at any time whenever we can support them. And then the last grouping of patients are the patients that are coming often from afar to Children's for cath and surgical procedures. So this pathway looks pretty similar to the one that we just discussed, but basically we're trying to gather all of the medical records that may exist at the referring institution, including any workup that has been done. We try to be super mindful and respectful and not repeat any evaluations that have already been done. So once we have gathered all that information, I'll meet with families again and kind of review what we have and what additional evaluations they may want to pursue. So oftentimes this includes genetic testing for families that haven't had that done yet, immunological assessments. A lot of children have not received a ciliary biopsy, so we can arrange that. And then from that point until the time they arrive, it's my job to kind of run around behind the scenes and coordinate all this stuff. So we try to, for example, immunology labs will grab those while the children are having their cath procedure. So they have a nice venous access in place. We can pull all the labs that we need and not save an additional lab stick for the patient. We'll collect ciliary biopsies when the children are under anesthesia for their preoperative testing, such as a cath procedure or for an MRI. And then we can also arrange that nasal nitric oxide screening as necessary in the pulmonary clinic preoperatively. So we kind of try to, get them all set up. And then once they arrive in Boston, we can kind of hit the ground running. Same for the other patients and other pathways. We remain available, if any issues or questions come up while the kids are inpatient, and then follow up with families as needed afterward. This is our lovely heterotaxy team. We are so indebted to all the folks that lend their expertise to improving the care of our patients. I'm not going to read through these names because I know that many of you in this room probably recognize a lot of folks on this slide, but we come together monthly and we review new patients that have been referred to the program. And it really is, I feel very fortunate to be working with all these individuals. I wanted to put a plug in for this publication that came out last year. Actually, Dr. Saba and Dr. Shidlow were a part of this publication. Families are often asking me, is there one document that I can bring back to my home teams to make sure that we are covering everything we need for my child? And this is that document. It is freely accessible on the web. There's actually an excellent table. I know you can't read that, but just to let you know that it exists, that goes through system by system of what families can ask for, with their local care teams.
If you notice it, Nisha
is
on that.
Oh, I didn't know that. Yay. Amazing. Perfect. Thank you for making that freely accessible. It's amazing.
Last family conference here.
Perfect. So kudos to you guys again, because it really is such an excellent resource. That's all I have. I included the QR codes for our program webpage, as well as a pamphlet that we made. That's a really basic guide for heterotaxy syndrome. It's available on the website. I'll also say, we're constantly updating the website so it can be a resource for families, especially those who are new to the heterotaxy journey. And we're hoping to add, more content as we develop it. We have a guide for managing asplenia that should be up there soon, which I think hopefully will be really helpful. That is all I have. So wondering about Holter monitors. Yes, that is part of our routine evaluation, because oftentimes the ECGs that you're having done in clinic will just be one snapshot in time. And oftentimes, there are patients, for example, with polysplenia who may have really low heart rates when they're sleeping. And that would be a patient that we would probably watch more closely to see, if that's something that could progress. So I would say yes, that is something that we recommend pretty routinely. Dr. Shidlow, please interject if you feel differently. So is the heterotaxy program only accessible for families who plan to use Boston Children's? Or is this available to get info to take back to your children elsewhere? We're always a resource. What I can say is that, our other providers don't have the capacity right now to see families virtually. I know that Kelly was talking a little bit about different funding and such. I'm able to see families across state lines. It's not something that I charge for all of our patients who are coming to Children's to have procedures. But our variety of care teams aren't able to do that. So what I would say is, first and foremost, you have this wonderful paper to bring to your home team, but we are always available to, provide advice for any family who's interested. Hopefully that answers your question.
I like the microphone.
As a military family, where we've got to tour many different hospitals and many different types of facilities with many different opinions on how to approach heterotaxy, what would you say, like you talk about collecting records and kind of, looking at the big picture for those where it's very difficult to get all that information compiled? Do you just approach it as they haven't had those and let's just do the tests? How would you do
depends on
that?
like what system you're talking about. So like many families will know if their child has had a ciliary biopsy for sure. So if that information, or they'll know whether or not their child has had genetic testing. Our program coordinator is like an expert at getting records when they exist. So if it's something like that, but if there are records, we should be able to access them. For things like maybe the immune assessments that, not sure if your child has had the immune assessment, I think that actually spelled out in the paper kind of says which immunological evaluations we recommend. So that should be helpful to a local care team who might be evaluating a patient locally. Does that answer your question? Yeah. So the question here is, should somebody so the genetic exome test is saying it's unlikely that she has PCD, but she might have mild asthma. I definitely can also, have Dr. Shidlow weigh in on this question. I would say from our perspective, we like to know more than less about our patients. So if a patient was followed at Children's and, the family was interested in pursuing these tests, we would move forward with them. What I can say is not all centers are going to be able to do this testing. I know that nasal nitric oxide screening, Dr. Sauber probably knows a heck of a lot more about this than I do, but nasal nitric oxide screening is not performed everywhere. Same as nasal ciliary biopsies. There's a technique in actually collecting the specimen, but also the pathologists who are analyzing that specimen. That's not available everywhere. So I would say, the most important thing is probably to see pulmonary, to screen closely for symptoms. And if there is, a high index of suspicion that there may be some ciliary dysfunction, that perhaps the local pulmonary team could direct, a family further in terms of where they might be able to get that testing. Does insurance typically cover all these screenings? I would say that it's not a problem that we have run into yet. For many families who are coming to Children's already, who are already going to be having surgery at Children's, we really haven't run into this problem. There's definitely been times where our program, administrative staff have to seek prior authorization before the child is able to see the specialist, but it isn't something that we really have run into. I guess for some children where there might be an insurance issue, those teams will just see the child while they're inpatient. So again, these are children who are already coming for a procedure. So we'll get all of the labs preoperatively and then have the teams come by during the inpatient stay. So it's kind of saving that outpatient clinic visit. It's probably not the best way to do it because there's obviously a lot of other focus going on when the child is inpatient. But we do try to work around so that insurance isn't a problem.
I'll just ask my question because I have the microphone. Sorry. So what wonderful. This is such an incredible program. And so I guess I have a couple of questions for you, Caitlin, but all the families around the country are probably thinking to themselves, this is such a great program. I want to be a part of it. And there probably are a number of heterotaxy programs around the country, but I'm not sure there are any that are this standardized and organized and comprehensive as the program you guys developed at Children's. And so the idea that I hope we can discuss maybe this afternoon when we have our provider meeting later this afternoon, I hope that the future is for there to be a large number of heterotaxy hubs around the country. that operate with the same protocols and guidelines, maybe that you guys started at Children's, so that people on the West Coast and in the South and in Texas and in the Midwest can all go to their local heterotaxy center and get the type of care that you offer at Children's. We're a few years away from that, but with that paper you presented and with kind of the pathway that you guys have created, we're going to get there soon enough. And so this might actually be something Heterotaxy Connection can lead the way in doing, is providing accreditation or site visits somehow to make sure that hospitals around the country are operating in a way that adheres to the way Heterotaxy Connection thinks we ought to take care of patients with heterotaxy. So we're getting there. And I see that there's a question that has my name on it here. This is Dr. Sab. Oh, I see. Okay, gotcha. So Jessica in the chat asked a question about PCD. Should I get more testing? I'm going to talk a lot about that tomorrow. There's a lot more to say about that PCD testing stuff. That's all I had.
I completely agree. And I hope that our program is the first of many. I would say that a lot of families, may come from a variety of different centers throughout the country. And once we actually sit down and review their records and review them with our team of subspecialists, there's often times where I'm able to say to families, hey, listen, you're getting excellent care locally, and there's nothing that we have to add. And I think that, families often breathe a sigh of relief knowing that they're in good hands locally. So I do think that that is a goal that we can aspire to. There's a question about genetic testing being inconclusive 5 to 9 years ago. Would it make sense to retest? I'll speak for our genetics colleagues and say yes, because the field of genetics is expanding quite rapidly, but I know we are going to be hearing from genetics tomorrow too. But in our center, we generally will see people every 2 years. So even people that have had that highest resolution test, the whole exome sequencing, our genetics team will see patients back every 2 years and reanalyze the data to see, have we learned anything else with what we know for this child, anything that might, help in terms of the genetics of heterotaxy diagnosis. So that is definitely a yes. We live in Dallas. So Caleb Prince, feel free to message me offline maybe. And perfect. Yeah. Yeah, we're happy to help whenever we can. So yeah, please reach out.
The question I was going to ask, so when you say you don't replace like the primary cardiologist or primary team, so I'm presuming like when you have kids there who, are already following a neurologist or following a GI or whatnot. So I'm just clarifying that what you do is kind of almost like a secondary consulting service, almost in a way,
Yep.
like that you are consulting with the primary team and not replacing a team that a family already has.
Yes. So we are a consult driven service. Each parts of our program runs a little differently. So genetics, we actually have a geneticist housed within the cardiac program, which is amazing. So she does see all of our heterotaxy patients and families, just her exclusively. But for pulmonary and immunology, they have very large staff. So, if our heterotaxy pulmonary providers aren't on service when there's a child inpatient who needs assistance, the goal is for them to be a program resource for the other clinicians on their team, and that they, for immunology and pulmonary could be seeing anybody within those departments, and that those providers could reach out. We also, I would say, since the GI piece is pretty new to us, we haven't done a lot of management with that, but basically, it was based on feedback that I was hearing from families who were coming to Children's to see genetics and to see immunologists and really wish they could have the expertise of a GI provider too. So that was really based on feedback from families. But we're always trying to work with the teams that are already currently in place and just kind of supplement the care that they're already giving.
Okay.
So I know you had mentioned that you have at Boston families that come from all over, who come from all around the world and all around the country. And a lot of those families, like our family, are coming to you seeking a second opinion, are wanting to know more than what their local team has told them. And in our case, the two institutions worked really well together. But I know something that a lot of our families have dealt with is their local hospital and their local team not being really on board with a family seeking a second opinion from someone like your program. Can you speak a little bit to, families that are experiencing that, kind of what can they do to help that process? And
You mean families who are coming to children's?
who want to come and seek a second opinion, but whose local team might not be really on board?
I might ask Dr. Shidlow to step in on that one. I would say it hasn't really come up for me because I'm typically meeting families after they're already in our system. I haven't really had folks reach out who aren't already coming to children's for cardiac care. So I might have Dr. Shidlow see if he can speak to that.
Caitlin, that was a great talk. Thank you for sharing about the program. I think that it depends a little bit on the individual situation. I can kind of think of two maybe broad categories. One is a family that wants additional information, kind of broadly speaking, about heterotaxy. And then some families reach out for a specific cardiology second opinion and also happen to have heterotaxy. I think I would just restate what Caitlin so nicely shared, which is that we want to be a resource for families, and we'll do everything that we can to support and help provide care. Sometimes the workup has been done and has been excellent in the local center, and we're happy to kind of reinforce that. And other times it makes sense for a family to come to see us. Sometimes there are, to be perfectly frank, insurance barriers that make that very difficult, especially if it's kind of the broader heterotaxy workup. With cardiac, sometimes the degree of specialization makes that insurance barrier a little bit lower, to be perfectly honest. But I think, again, our goal is really to be a resource. And I think, people come to our program from any number of different avenues. It could be a primary cardiologist reaching out. It can be a cardiac surgeon reaching out. It can be a non-cardiology provider. It could be a parent as well. And our goal is never to replace any providers that you've had an established relationship with. And it is our goal to be as collaborative as possible. If your local providers are really resisting, all I can say is maybe perhaps direct them to our website and or even direct them to our talks, and just reiterate that we're here to be collaborative and share education and information wherever possible.
I guess I'll just take a minute. So for those who haven't read the consensus paper, I would really encourage you to do so. Like for me, I came into this world just a few years ago and felt like I was drowning at first, trying to understand it, trying to help my daughter. And like reading through that paper, I understand a lot of what's going on better. It explains it really well. Like the doctors who collaborated on it, you can tell they did it was a lot of hard work and a lot of thought went into it. So anyway, there's my 2 cents on the consensus paper.
Thank you. Oh, you're